Today I am going to discuss about phosphate metabolism. I am Dr. Samir from Department of Critical Care Medicine at IMS and Some Hospital. So why is phosphate metabolism important for us? The phosphate, when I say phosphate, what does it come to our mind? Some it may come bone, to some many phospholipids, cell structure and all, and also it is the most important in cellular energy. Why? Because the source of energy for the cell is ATP, adenosine triphosphate. So that is why phosphate is very important, because it is necessary for the energy of the cell. So coming to the various roles of phosphates in our body, one is your energy metabolism. That is a part of adenosine triphosphate. So that is why phosphate is so important. Our cell needs energy for every functioning of our system. It needs energy, and that is provided by adenosine triphosphate, which has phosphate in it. So energy metabolism. And what else? It also helps in cellular signaling and nucleic acid metabolism. Membrane integrity, as I said, phospholipids and all. And of course in bone mineralization. So calcium and phosphorus are the most important constituent of our bone. So it is important for bone mineralization. Now our body has stores of around 1000 gram in case of females and about 1500 milligram in case of males. And out of this, majority of the share of the phosphorus is present in the bone, like 850 grams out of 1000 grams, that is 85% is present in the bones. Now the phosphorus in our body is present as an organic form or in the inorganic form. So 30% versus 70%. So of the 30% inorganic phosphate, 10% is protein bound, that is not filtered by the kidney. And of the 90% ionic phosphate, 65% is around free ionic. So hydrogen phosphate, sodium phosphate account for around 75% of the ionic phosphates, and dihydrogen phosphate about 10% of the total phosphorus levels. The normal plasma levels of the phosphorus or phosphate in our body is about 2.8 to 4 milligram per deciliter, or in millimoles it is 0.9 to 2.3, and most of it is present as inorganic orthophosphate. Now the organic phosphates are those constituent the membranes, cellular membranes, like phospholipids, phosphatesters, phosphoproteins, phosphonucleotides. It has a pK of around 6.8, so it is present as a divalent ion at a physiological pH in our body. So basically phosphate, PO4 minus, that is an inorganic molecule. As for organic, generally we need carbon and hydrogen, hydrocarbons, but inorganic molecule is phosphate, PO4 minus. It has 4 oxygen atoms and a central phosphorus atom. Now the phosphate in our body, let's discuss that its absorption is mostly in the duodenum and jejunum. So we intake, there is intake of phosphorus, there is absorption mostly in the duodenum and jejunum, maximum in the jejunum. It is highly efficient. It is by both passive and active mechanism. So that is along the concentration gradient. The passive mechanism is paracellular, that is in between the cells, and active is by some transporters, phosphate transporters present on the luminal side of the gut. So we will discuss in detail later. So basically phosphate is absorbed and phosphate is excreted. How it takes place, we will discuss. The absorption from the gut to excretion in the kidneys. So the factors depending on the phosphate levels in our body, there can be increased or reduced absorption, there can be increased or reduced excretion depending on the levels of phosphate in our body. So what are the factors that control? We will be reading. So intracellular transport and across basolateral membrane, that takes place along the concentration gradient. So intercellular junctions are basically impermeable to phosphate. That doesn't mean that nothing goes to it, which I said previously. The passive transport is between the paracellular, that is between two cells. The intercellular junctions are mostly impermeable, so that is not a major part of phosphate getting into our cells, but still that is also a part. Now coming to transcellular, there are three components. One is your luminal sodium phosphate cotransporter. Second is your basolateral sodium potassium ATPase compound. Then third is your basolateral direct phosphate transporter which is yet unidentified. I will show that in a figure later. So, and other non-hormonal factors which affect our absorption and all. So, high level luminal levels of calcium in the gut. If there are high levels of calcium and phosphorus, they generate insoluble calcium hydrophosphate. So, complexes which are basically not absorbed. And the antacids if people take which contains your salts like magnesium, aluminium, they form complexes of salts with phosphate and renders them unabsorbable. So this is the figure that I was talking about. We can see those green dots are the phosphate molecules. So they can be paracellular, that is between the gap junctions, which are mostly impermeable. So only very minimal amount of transport takes place through that route. And then there is our transporter, NPT2B. So NPT2B is mostly present in the gut epithelium. So that is a sodium phosphate cotransporter type 2B. So when the phosphate load is there in the gut lumen, so that is transported by via this NPT2B, and it is seen that, or it is known that vitamin D by a method mostly by transcription, it upregulates the expression of NPT2B on the luminal side when there is reduced phosphate in our blood or in our body. So vitamin D upregulates phosphate intake. And what are the factors that regulate phosphate uptake? We will read. So this is the basic mechanism. One is paracellular, one is transcellular. Transcellular is by NPT2B on the luminal side. On the basolateral side, there can be sodium potassium ATPase or a unidentified phosphate transporter. Now coming to the renal excretion part, so that is the absorption part. Now coming to the excretion part. Then in between what happens, we will again read. So coming to the excretion part, the circulating and extracellular phosphate levels are essentially a function of renal reabsorption. So although absorption takes place, whether that is kept by our body or released by our body depends on the phosphate levels and it depends on the kidneys. So even though there is phosphate absorption accordingly along the concentration gradient, the phosphate levels to be maintained in our body is determined by the renal reabsorption or excretion. So if there are high levels, there will be excretion. If there are low levels, there will be reabsorption. So phosphate is completely reabsorbed when the plasma concentration is below 1 millimole per liter. Now the circulating phosphate is freely filtered by the glomerulus, and 85 to 90% of it is reabsorbed. So maximum reabsorption takes place in the proximal convoluted tubule, then in the loop of Henle, and then in the distal tubule. So reabsorption here, it takes place by NPT2A. In gut, we had NPT2B, and in the renal, PCT proximal convoluted tubule, we have NPT2A, the sodium phosphate transporters. So here, active transportation in the proximal tubule, this requires luminal sodium as a co-transportee. So basically, there are three gene families of sodium phosphate co-transporters. Type 1, which is NPT1, 3, and 4. Type 2, so there are 3 in number. So luminal is NPT2, gut lumen is NPT2B, that is intestinal. NPT2A is in kidney PCT, and NPT2C is fetal. And type 3, there is PIT1 and 2. So they maintain intracellular phosphate levels mostly present in the basolateral side. So here these are the other receptors we will read gradually. So this is NPT2A expression and internalization depending on the phosphate levels. The other factors that contribute to your phosphate levels in our body, they are the SFRP, parathormone that binds to PTH1 receptors. Then we have staniocalcin, we have vitamin D, we have FGF23, and we have clotho. Now what are those? We will see. So basically, in the renal, glomerulus, that is total complete free filtration, is regulated by feedback mechanism. In the PCT, proximal convoluted tubule, we have NPT2A and C in case of fetal, and sodium potassium ATPase form. So how the absorption or reabsorption or excretion takes place? It is due to the ECF variation. The ECF concentration of phosphate variation regulates your reabsorption. And the transepithelial transport is regulated by the phosphate load or parathormone and FGF23. Clotho, they inhibit reabsorption. They are basically phosphatonins. They reduce the phosphate levels. Like calcitonin reduces your calcium levels. Phosphatonin, they reduce the phosphate load. So parathormone, it stimulates excretion. FGF23 and clotho, they inhibit reabsorption. This is the way they reduce the phosphate load. Parathormone by promoting excretion, and FGF23 or clotho by inhibiting reabsorption. In the loop of Henle thin part, ascendingly no active transport, and along with water and urea reabsorption, the phosphate reabsorption takes place. LOH thick is very extremely low, doesn't matter. And in the distal tubule and collecting ducts, the reabsorption is parathermal driven. So if the phosphate levels are low, parathermal is reduced, and so there is reabsorption. Basically, parathermal inhibits reabsorption. So the parathermal levels are low, so it promotes reabsorption. And if the parathermal is high, if there is high phosphate levels, there is high parathermal levels. The distal tubule and the collecting duct, so there is reabsorption, that is mostly parathermal driven. It is independent of the sodium. Like in proximal convoluted tubule, dependent of sodium. Your distal convoluted tubule, it is independent of sodium. So the parathermal inhibits reabsorption and promotes excretion. The low phosphate levels, they suppress the level of PTH, and so there is reduced excretion. So coming to the regulation of metabolism, how does the regulation takes place? Vitamin D, how does it affect? And other factor also we'll discuss. Vitamin D, as we saw earlier, it increases the gut absorption of phosphates. It upregulates the NPT2B co-transporter in the gut, and it upregulates your NPT2 expression in the kidneys. So it increases your gut absorption and also your renal reabsorption. So increases calcium and phosphate reabsorption also by the epithelial cells of the renal tubules. Now coming to parathormone, as we know, it helps in bone resorption, increased calcium and phosphate in circulation. So they act on the PCT, that is reduced reabsorption, so more of excretion of the phosphates. So the net result is your hypophosphatemia. Although it increases phosphate level by bone resorption, but its more effect is in the PCT. So net result is a hypophosphatemia. It also promotes formation of the active vitamin D by upregulation of renal 1-alpha hydroxylases that causes your 125 dihydroxy vitamin or calcitriol. So they enhance phosphate absorption, but still that is not as significant as the reduced absorption of phosphates. So net result is a hypophosphatemia. So whenever there is a hypophosphatemia, in the second step we see, so there is a fall in phosphate and there is a rise in 125 dihydroxy polycalciferol or calcitriol, as I said. So that causes increased phosphate from intestine absorption, that causes fall in PTH levels, and that also leads to increased calcium absorption from the intestine. So fall in PTH levels, leads to reduced excretion of phosphate and more absorption of reabsorption of phosphate. So that is return to normal levels of phosphates, and there is increased phosphate absorption from the intestine, that again leads to normal serum phosphate levels. Now FGF23 or fibroblast growth factor, it is a phosphatonin, as I said, reduces phosphate levels. So it enhances phosphate excretion, it downregulates the phosphorus transporters on the luminal side of the renal epithelium. It also inhibits 1-alpha hydroxylase activity in kidney, thus reduced expression of vitamin D and reduced expression of your NPT2A and B in renal and gut epithelium. So circulating phosphorus drives your FGF23 release. So if the circulating phosphorus levels are high, it increases your FGF23 release, and there is toning down of phosphate levels in our body. But in healthy subjects, normal phosphorus intake does not influence your FGF23 levels. Now coming to SFRP4, soluble freezer related protein 4. It is also a phosphatonin. It is expressed by the osteoblasts and some cells in the kidney. Basically, it antagonizes WNT signaling. So the three possible mechanism of actions. One, it is inhibits metalloproteinases. These metalloproteinases, they cleave your FGF23 into inactive form, okay, which has a TMP-like domain. So as we know that FGF reduces your phosphate levels. Now MMP cleaves your FGF, so it inhibits MMP. So higher FGF level, that leads to reduced phosphate. So it is a phosphatonin. The absence of WNT signaling, as we saw, it inhibits that in osteoblasts, so there is reduced bone formation. Thus, the requirement of phosphate requirement goes down, and so reduced phosphate reabsorption from the kidneys because there is less requirement. It also inhibits vitamin D production via 1-alpha hydroxylase, so there is more phosphate excretion and less reabsorption. Now coming to MEPE, matrix extracellular phosphoglycoprotein. This is also a phosphatonin that reduces the phosphate levels. So 45 to 65 kilodalton glycoprotein, that belongs to the sibling, that is short integrin binding ligand glycoprotein. So cathepsins cleave MEPE or phosphoglycoprotein to form an 18 amino acid C-terminal peptide. So this peptide, it causes inhibition of mineralization and the promotion of urinary phosphate loss. So this is what, so from MEP we get a peptide that inhibits your mineralization and promotes urinary phosphate loss that leads to low phosphate levels. Now coming to staniocalcin 1 or STC1, this one helps in increasing phosphate levels in our body. So this promotes phosphate uptake. This is made by collecting duct epithelium. This mediates the osteoblast phosphate uptake in bone via the PEAT1 transporters. We had read earlier there are 3 types of transporters. This is the third family. So this also drives expression of NPT2A in kidneys. This is a hypothesis not yet proven, but this is also thought to be a method of increasing of phosphate levels in the body. Now coming to hypophosphatemia. So what if there are low levels? And so hypophosphatemia is basically seen in 5% of all hospitalized patients, not only in ICU but all hospitalized patients in hospitals. However, according to this study published in Journal of Critical Care in 2013 by Satoshi Suzuki, it says that in ICU the incidence of hypophosphatemia can go up to 26%. That is quite high. And why is phosphate important? We have already studied, and see how does it affect. So basically, what are the mechanism of hypophosphatemia? There are 4 mechanisms: redistribution, reduced absorption, increased renal loss, and renal replacement therapy. The most common method of hypophosphatemia is your redistribution of phosphate from our blood to various tissues or whatever. We'll see. So it is very common in ICU and post-surgical patients. So basically, when there is a severe stress on the body, maybe because of the surgery or because of the patient is in ICU, there is internal redistribution, and because of the acute stress, there is whenever the patient is in acute stress, there is release of epinephrine, there is release of glucagon, there is endogenous stimulation also, and also the release of insulin in case stress or whatever, there is intracellular shift along with the glucose, and this cause your redistribution of phosphate from the blood into the cells, into the intracellular compartment. So that causes hypophosphatemia. So what does this strike in your mind first when I say insulin causes intracellular shift? And when there is an insulin surge, right, that is your refeeding syndrome. So when after prolonged fasting or anorexia or malnourishment due to chronic alcohol intake, there has been a severe lack of energy and nutrition over the past few days, in many days. So whenever the patient suddenly goes into normal feeding, normal amount of calories, normal amount of proteins, so that is called a refeeding syndrome. The patient was not taken for so many days and suddenly we give him a normal diet. So that causes an insulin surge. A huge amount of insulin is released when there is a refeeding takes place, and that causes internalization of your phosphates, that is redistribution. So there is hypophosphatemia, hypomagnesemia, and that causes your shift, and there is hypokalemia. All these intracellular shifts takes place, that is redistribution, and the causes in refeeding syndrome. And very severe form of refeeding syndrome can cause your coma, delirium, and all. Okay, so hyperglycemia and subsequent osmotic diuresis, they are treated with insulin. That can also cause your hypophosphatemia. Very high levels with patient with DKA, patient with HHS or hyperosmolar coma, they come to you, hyperglycemic coma, they come to you and you start insulin infusion. Very high doses of insulin infusion is given, and that causes internalization of phosphate. That can also lead to hypophosphatemia. Now, respiratory alkalosis. Respiratory alkalosis causes a reduced intracellular pH, that is a compensatory acidosis type, and that stimulates glycolysis, and that causes hypophosphatemia. And post-parathyroidectomy, thyroidectomy, that is hungry bone syndrome, so that can also cause a hypophosphatemia. Hungry bone, more and more uptake of phosphate in the bone, and that will cause hypophosphatemia. So GI phosphate loss in chronic diarrhea, vomiting, or antacids, as I said, antacids, this is the GI loss, antacids, the calcium, and the magnesium and the aluminium, they combine with your aluminal phosphate and they form unabsorbable compounds. So the phosphate intake goes down. Renal loss, maybe because of diuresis or acute volume expansion, they leads to renal loss of phosphates. So again, overlook internal redistribution, hormonal triggers like insulin, glucagon, epinephrine, dopamine, drugs like carbohydrate infusions, beta-2 agonists, steroids, xanthan derivatives, respiratory alkalosis, like because of maybe mechanical ventilation, hyperventilating the patients, or sepsis, alcohol withdrawal, hepatic coma, anxiety, salicylate overdose, And glucose shifts, like I said, decay, refeeding after malnutrition, rapid cell uptake, like I said, hungry bone syndrome, renal losses because of drugs like diuretics or antivirals like tenofovir or your anti-cancer imatinib, and acute volume expansion. These are the various causes of hypophosphatemia. So ICU patients are more prone to hypophosphatemia. As we saw, the incidence can go up to 26%, and that is associated with higher mortality. Now, symptomatic hypophosphatemia takes place generally when the levels fall below 0.32 millimoles per liter. Now, symptoms are basically due to impaired metabolism. As I said, it is the energy of the cell. So, cellular energy goes down, that leads to impaired metabolism. So, there is muscle dysfunction, there is myalgia, patient has breathing difficulties, there is respiratory failure, there is weaning failure, reduced myocardial contractility. So, increased inotropic requirement in patients of septic shock because all your cellular functions are going down because of the low phosphates. So, there are all these basically all organ systems go into a reduced function. So that is why it is very important. So the phosphate levels to be maintained, and also fall in the 2,3 DPG levels, they causes hypophosphatemia. The problem with this is the fall in 2,3 DPG levels. There is a left shift of oxygen dissociation curve. So the oxygen remains bound to your hemoglobin, and they are not delivered to the tissue. So that is the problem with the left shift or low levels of 2,3 DPG. And in hematological consequences of hypophosphatemia, there can be hemolysis, there can be leukocyte dysfunction. So that leads to your impaired phagocytosis and granulocyte chemotaxis. So there can be higher chances of infection, reduced ability to fight with infections. Patients easily goes into sepsis and easily develops sepsis and gets your hospital acquired or ICU acquired infections of gram-negative bacilli or your other infections that are prevalent in your ICUs or hospitals. Hypophosphatemia also leads to insulin resistance, and also it causes ileus. As we saw, cellular activity goes down, the motility goes down, the contractility, the peristalsis goes down, and that leads to ileus of the patients, abdominal distension, reduced intake of food, and the severe form of refeeding syndrome, as I said, altered mental status, delirium, seizures, and coma. And there are also chances of peripheral and central neuropathies. Basically, all systems are affected if there is low hypophosphatemia because it is the energy of the cell. So basically, all types of tissues goes into a reduced functioning shutdown, and that involves each and every system of our body. So respiratory system, it is failure, infradiaphragmatic contractility, failure to win from mechanical ventilation. In cardiovascular, there is decreased myocardial contractility, decreased stroke volume, increased inotropic requirement, arrhythmias, and metabolic, there is insulin resistance, depletion of 2,3 DPG. So this left shift of oxygen dissociation curve. Neurological, the severe form of refeeding syndrome, that can be delirium, seizures, and coma. There's GI system, that is dysphagia, ileus, hematological, as I said, hemolysis, leukocyte dysfunction, reduced phagocytosis, and increased chances of sepsis. And in musculoskeletal, we get weakness and myalgia. So the treatment, normal, if there are no symptoms, basically only diet, the body will take care of it. As I said, renal reabsorption of the falls below critical level of 0.32, there is complete reabsorption of phosphate from the renal system. So does not always necessitate treatment. However, if it falls below 0.64, it is better to replace. We can give enteral or parenteral replacements. And the enteral replacements can be, I will see later, I will tell which are the enteral replacements, but they should not be taken with your antacids. The antacids that have aluminum, calcium, and magnesium, that will form insoluble complexes. And less than 0.32, we should always go for parenteral replacement. So basically, phosphate is a very high concentrated salt, so we should always give through a central venous line. So acute replacement, and it should be done over hours, like 8 to 10 hours, 7 hours, 8 hours, 10 hours, 12 hours, because sudden immediate correction of hypophosphatemia can exacerbate your hypocalcemia and cause metastatic soft tissue calcification. So whenever there is hypocalcemia, it is better you first correct your calcium and then don't go for your phosphate correction, else it will exacerbate your hypocalcemia. So what has to be given? Like for oral, we can give phosphate sandose, glycophos or adifos, and for IV we have potassium phosphate, we have phosphate polyfusor, and we have potassium dihydrogen phosphate. And these have to be given over central line and over a period of 8 to 10 hours. The higher the duration, better. There should be gradual replenishment of the phosphate levels, else it will exacerbate your hypocalcemia. Now coming to hyperphosphatemia. So again, hyperphosphatemia, there are 4 mechanisms. So there is acute phosphate load, cellular shift, reduced renal clearance, and pseudo hyperphosphatemia. Now the load can be exogenous or endogenous. So increased load on the body. Exogenous as in laxatives or high dose phosphonatoin laxatives, and they cause volume contraction and renal impairment. So there is increased reduced filtration and more in the stays in the blood, and volume contraction again leads to increased concentration of phosphate in the blood. So these are the exogenous method, and endogenous method is the tumor lysis or rhabdomyolysis. So there is cellular rupture, so the release of all the cellular intracellular contents into the blood, and phosphate levels goes high in mostly tumor lysis and rhabdomyolysis. The problem with this is that will come in pseudo. I will tell. Cellular shifts, the diabetic ketoacidosis and lactic acidosis. So like that time we saw respiratory alkalosis, it increases glycolysis. Lactic acidosis and diabetic ketoacidosis, they reduce glycolysis rates. So there is cellular shift and there is hyperphosphatemia. There is release of phosphate into the blood. Now AK and CKD, so that is reduced GFR, so less amount of phosphate is filtered, so it levels remain high in the blood. Now coming to pseudo, as we said, hyperglobulinemia, hyperlipidemia, hyperbilirubinemia, and hemolysis. As I said, like in your hemolysis syndrome or something. So suppose in this is why pseudo, because in hypophosphatemia, there we discussed, the patient has myalgia, there is muscular cramps and pain, and severe form of phosphatemia can lead to your rhabdomyolysis. Now because of rhabdomyolysis, there will be increased phosphate surge in the blood. So basically the patient has myalgia or rhabdomyolysis because of the hypophosphatemia, but release of phosphate into the blood causes hyperphosphatemia. So that is what is pseudo hyperphosphatemia. So pseudo hyperphosphatemia can be seen in hyperglobulinemia, hyperlipidemia, hyperbilirubinemia, and hemolysis. And drugs that cause hyperphosphatemia, the heparin and amphotericin B. So overall picture of hyperphosphatemia, the causes: acute phosphate load, that can be because of hemolysis syndrome or rhabdomyolysis; exogenous phosphate like your phosphate laxatives, phosphonatoin, volume contraction, and cellular shift as we saw in metabolic acidosis, and decreased renal clearance in AK or CKD, increased tubular reabsorption because of parathyroid or pseudo hypoparathyroidism, bisphosphonates, vitamin D toxicity, acromegaly, and pseudo hyperphosphatemia, endogenous, exogenous. Endogenous can be hyperglobulinemia, hyperlipidemia, hemolysis, hyperbilirubinemia, and exogenous that can be because of drugs as heparin and amphotericin B. So the effects, but how does hyperphosphatemia affect us? So hyperphosphatemia generally we rarely come across hyperphosphatemia because the body hemostasis is quite good in maintaining phosphate levels of our body. Very rarely we see hyperphosphatemia, and mostly it is seen in patients with AK and CKD and or pseudo hyperphosphatemia. So in AK CKD patients, what is the problem? There is a hyperphosphatemia, as I said. Hyperphosphatemia lead to your hypocalcemia, and hypocalcemia can lead to tetany. So these are the effects of hyperphosphatemia, and also it has negative inotropic effects on the myocardium. So treatment is treat your underlying cause. What is the cause? Your endogenous cause, or laxatives, or whatever, or the drugs, or you treat your hypophosphatemia for pseudo hyperphosphatemia. You may treat hypophosphatemia and your intakes vitamin D levels, treat serum calcium. So that all treat the underlying cause, or as I said, it is most commonly seen in AKI CKD patients. You may go for renal replacement therapy. You can go for dialysis, SLAD, whatever. So you have to go for renal replacement therapy. So this is the treatment of hyperphosphatemia. So basically what we saw is hypophosphatemia is more common in ICU than hyperphosphatemia. So hypophosphatemia, we see it has several side effects. It affects all our systems. So your take home message should be that you should always be wary of hypophosphatemia. It causes multi-organ dysfunction. It can cause weaning failure. It can increase your inotropic requirement. It can cause sepsis. It can cause hemolysis. It can cause neurosis, delirium, coma, alternate mental sensorium. So basically, it increases the morbidity of the patient, increases the ICU stay. So treating hypophosphatemia is very, very, very important for us in the ICU. Okay, so basically, take home message is again hypophosphatemia. Treat hypophosphatemia. It can affect every system. Correction can be given orally or enterally or parenterally. The parenteral should be through CVC and over long duration, 8 to 10 hours. Treat calcium first, then go for your phosphate correction. Okay, so that is all. I hope you have enjoyed the session. Thank you.